morning everyone. Before we begin today, I would like to acknowledge the traditional owners of the land we are standing on today, the Whadjuk people of the Noongar Nation, and pay our respects to elders past, present and future. Welcome and thank you for joining us today. My name is Vilma Fitzgerald and I'm a Senior Research Officer at the Australian Indigenous HealthInfoNet, and I work on the Alcohol and Other Drugs Knowledge Centre project. We're located at the Edith Cowan University, Mount Lawley campus in Western Australia. Today's presentation is one of a series of webinars produced by the Alcohol and Other Drugs Knowledge Centre, which is funded by the Department of Health. We are pleased to introduce our guest presenter, Dr. Sara Farnbach from the National Drug and Alcohol Research Centre, NDARC, at the University of New South Wales. And NDARC is one of the 3 collaborating centres that we work on with the Alcohol and Other Drugs Knowledge Centre project. Dr. Sara Farnbach is a postdoctorate research fellow with a passion for improving the health and wellbeing of vulnerable communities through evidence-based and tailored health service delivery. Her PHD research focuses on facilitators to conducting high-quality and culturally appropriate research focused on strengthening wellbeing for Aboriginal and Torres Strait Islander communities. Just to advise that we will have about 5 minutes at the end of the webinar for questions, so we ask that questions are saved for the end of the presentation. Thank you. Good morning, Sara.
Excellent. Thank you kindly for that introduction, and good morning, everyone. Thank you for dialing in so early on a Monday morning. So today I'm going to talk to you a bit about some research that I've worked on where we've talked to Aboriginal and Torres Strait Islander people about their experiences with primary healthcare. In particular, talking about their experiences talking about substance use or depression or mood when they've visited primary healthcare services. So we'll get started, but before I begin, I just wanted to also join Vilma in showing my respect and acknowledging the traditional custodians of the land for where I am, which is here in UNSW in Sydney, which is the Bedigal people, as well as for around all the nations of Australia where everyone might be joining us from today. I'm just actually going to turn my video down so that you can focus and look at the slides, but I'm still here, don't panic, and I'll turn the video on at the end so we can chat face to face. Okay, so I've split today into 4 sections, sorry. And firstly, what we'll do is we'll just look a little bit at why we think it's important to talk about or to consider how we work with people in primary healthcare around substance use and around mental health. Next, I'm going to present 2 pieces of research that we've worked on. The first one is focused on clients' experiences speaking about substance use in primary care. And the second is talking about experiences talking about mental health. So these are mood disorders, including depression, post-traumatic stress disorder, and anxiety, also in primary care. And then finally, we'll just bring these pieces of research together to identify a couple of take-home messages and clinical implications. Okay, so our background. So as I'm sure you all know, many Indigenous people have really good mental health and don't use substances at all. So for a lot of people, this won't be, these conversations that we're having today won't be needed. But similarly, in all communities around the world, there are some people who have problems with mental health or with substance use, and for whom healthcare or treatment, referral or assessment might be useful for. For many people, primary care is the first point of call, as I'm sure you all know. So this is general practice and can include Aboriginal medical services and the community-controlled health sector. And primary care can have a really important role in that people sometimes visit there when they're seeking support for their mental health or substance use, but they also have the opportunity within primary care to identify problems that perhaps the person wasn't actively seeking treatment for. So it's a really important part of the health system that can actually link people with services that they may or may not have identified that they need. As we all know, look, there are some problems sometimes with accessing support for mental health and for substance use in primary care. And we've heard this is for a range of reasons. Sometimes there are concerns on behalf of staff about asking about mood disorders or about substance use in primary care. This could be concerns about upsetting people or offending them. or sometimes it's to do with stigma on behalf of the staff or sometimes both people. As we're aware, often time constraints and resource constraints. We have short consultation times, and there's often not a lot of resources, including referral resources available, as well as sometimes access to training for staff to develop specialised skills in mental health and substance use screening, referral and treatment. So this is why we set out to do this research, was to really unpack a little bit around what's going on and how the current experiences of people who are visiting primary care. So our first study that we did that I'll present to you today came about because I was talking with a GP who's an Aboriginal GP who has worked at a range of primary healthcare services, including in the community controlled health sector. And he said, I don't know, he was working at a residential drug and alcohol treatment centre at the time. And he said, I don't know why I don't see the men who are here receiving rehab treatment at the drug and alcohol treatment service. I don't know why I don't see them in primary care. The first time I see these men is when they present for treatment. So we set out to conduct this research to really explore what the experiences were of the men who were at the residential treatment service when they visited primary health care. Do they visit at all? And how do those visits go when they actually do seek support from primary care? We also wanted to know a bit about their preferences for accessing primary care, about their substance use. So I won't labour too much on the methods, but just to let you know, this is a qualitative study. So we conducted semi-structured interviews that were conducted by Indigenous researchers at the residential rehab service. So in total, we spoke to 20 Aboriginal men who were all resident at the residential drug and alcohol service at the time. So they were in treatment for substance use. Most of the men, they were all from New South Wales. Most were from rural, remote or regional New South Wales. And most were either hadn't had any previous treatment stays in rehab or were on their first treatment stay. The average age of the men who we spoke to was about 27, and most had been in employment of some description in the last 12 months. As you can see on the right there, ice or methamphetamine was the most commonly used drug by men before they came into treatment, but cannabis and alcohol were also reported. So from these discussions that we had with these men in treatment, two major themes were developed. So I'll talk you through each of these themes now, and I'll pick out the parts that I think are particularly relevant for today's conversation. So the first theme was around asking for help for substance use, and this also included mental health problems that the men had that they considered to be linked with the substance use. And I'll describe this a little bit more in a moment. The second major theme was around a supportive and enabling primary healthcare setting to facilitate these conversations. Okay, what we've got here is this first theme around asking for help for substance use. The kind of brownie coloured white boxes at the bottom are quotes that we collected from the men who took part in this study. I won't read them out because you can read, but I'll just talk to you and just describe what's happened in each of these themes. So what we found was that of the 20 men who were in treatment, about half of them, exactly half of them had actually spoken to somebody at a primary healthcare service about their substance use. Now this was sometimes the GP, it was sometimes a nurse, but it was also an Aboriginal health worker, and it was sometimes in fact reception staff when men were trying to seek appointments and book appointments. So they would go in and say, I need help, I want to see somebody for my substance use. So that's great. So we found that about half of the men actually had initiated these conversations at some stage. And look, they did this when it caused a problem. So as you can see here from this quote, that men sought support from primary care when their substance use was at a level that they described as problematic. They also reported speaking to GPs most commonly when they knew them already. So if they had an established relationship with the GP from a previous visit, this was the time that these were the GPs that they went back to see. As a result of these conversations, some of the men were not offered any treatment. So again, as you can see here in this quote, I won't read it out, but you can see here that this GP, after having these discussions, didn't think that this client, this man who was asking for help for his substance use problems, actually needed to go to rehab. He said, "You'll be right, just tough it out." But on the other side, many men were in fact referred for treatment, and this is great. So this is the outcome that we're after. You know, we've got these men who have identified that they have a problem with substance use, and they're going and they're asking for help in primary care, and they're getting some referral to treatment. So this is a great outcome. The flip side of that was that there were some men who were referred to treatment who didn't actually want to be referred to an external service. So you can see here from this quote in the bottom box that although this man was referred for treatment, he actually wanted to be treated by the primary healthcare service that he'd visited. He didn't want to go elsewhere. And as you can see here, this man was actually came into treatment in the end through the justice system. So this is possibly a missed opportunity for treatment that occurred as a result of this external referral when it actually wasn't what the gentleman was after. So next, a lot of the men who we spoke to reported that they were unable to tell the whole story about their substance use to the health staff that they spoke to. And this was for a range of reasons. Often they related to fear. So this fear was to do with if they told the GP or the health staff about their substance use or the extent of their substance use, that they would receive bad news about their health. They might be judged as a result of what they disclosed. They were worried about stigma. And also, as you can see from this quote here in the bottom box, a couple of men described that they were concerned if they told the GP the full story, that they might have a visit from docs or might be at risk of losing their kids as a result of telling the full story. Also, many men spoke about being unable to access primary care because of their substance use. You can see this quote here. This man's describing the experience of being wrapped up in the drug world and how that was a real barrier for him accessing treatment. The other thing that was mentioned by one client was he was concerned about talking and telling the full story to his GP because of confidentiality concerns. So this was because this client knew the GP quite well, and the GP knew their family and had for a long time. And they were concerned that if they told the GP the whole story about what was going on with them, then this story might get to them and back to their community. This was only reported by one man though. Okay, so on to the second major theme. So this was about having a supportive and enabling primary healthcare service. Many men, most of the men, in fact, talked about the importance of being able to see the same GP at each appointment when they came into the clinic. As you can see here from this quote, a lot of the men felt that it was very difficult for them to tell what was often traumatic and difficult stories about their past and current situation. They wanted to tell the story once, have the GP be aware, and then be able to move on with the conversation and with their treatment, rather than having to describe their situation again and again at each appointment. Many men spoke about the importance of being able to see Indigenous staff. So these were often Aboriginal health workers or Aboriginal nurses or GPs. They felt that when the clients shared the same cultural background to them, that they understood, when the health staff shared the same background as them, that they understood the reasons and the causes for their situation and for some of their decisions. And this was something that the non-Aboriginal staff, they felt, weren't able to do as well. Many men spoke about the importance of having a support person. So this was usually a family member or a friend who attended appointments with them and prompted them to follow up on the discussions that were made during appointments. Most of the men actually had a support person, and they reported that this was a really important part of them actually going along to see primary care in the first place, and then actually acting on and following up on the plans that were made during those visits. So finally, at the residential treatment service, there was a strong focus on cultural support and on developing connections with culture and community. And this was something that the men in treatment really valued from the treatment service. And it was something that they saw as being a really central part of their ongoing treatment once they left the service. Many men talked about how their culture had been stolen and that they thought it was really important for them to continue to develop and foster their cultural connections. As you can see here from this quote at the bottom, this man thought it was really important for him to keep that connection going beyond his stay in the treatment centre. So the second study I wanted to talk about relates to the experiences of staff and patients about mood and social and emotional wellbeing disorders. So let's get into it. So this study was linked with a larger study called Getting It Right. I'm not sure, some of you may have come across it already. The Getting It Right study was set out to validate or test the culturally adapted depression screening tool called the APHQ-9, or the Adapted Patient Health Questionnaire. And the study that we did alongside this main study was to talk to clients and to staff about their experiences and willingness talking about social and emotional wellbeing research during the research project. So similarly, we used grounded theory approaches, and the research was also guided by an Indigenous advisory group. I'll come back a little bit to the APHQ-9 at the end. So who did we talk to as part of this research? So we spoke to staff and we spoke to clients. In total, we spoke to 36 Aboriginal health workers, managers and GPs. And we did research interviews with these 36 staff after the main project was over. So they'd already gone through the process of conducting interviews and talking with clients about depression as part of the main project. We conducted semi-structured interviews with the staff, mostly in person, and we also did some second coding to verify the themes. We looked at the data that the staff provided and the reports of their stories and experiences alongside that of the Indigenous patients who took part in the research. So we also collected information from 500 adult Aboriginal patients who were part of the research study. And these patients had visited a primary healthcare service. So it was usually an Aboriginal community-controlled health service or a health service that had a large Aboriginal population. And it was conducted that we collected feedback from patients during the research project. So they'd literally just finished doing the interviews as part of the research project, where they were discussing mood and discussing suicidal ideation, thoughts of self-harm as part of the research project. And then we asked them for some feedback about what they thought about the research. This feedback was collected not by us as the researchers, but by the primary healthcare staff. So this was the GPs, Aboriginal health workers and nurses who worked on the research. And they collected feedback by way of structured feedback questions and also open-ended questions. So in total, we collected feedback from 500 Aboriginal clients in primary care, and the mean age of clients was about 43 years old. And so this was from right around Australia. We had 10 communities who took part in this project. And so we had about 50 people from each of the 10 communities who contributed information to this project. So 3 major themes were developed as part of this project. I'll talk you through each of these now. Similarly, I won't go through all of them. I'll just talk about the parts that I think are really important for today's discussion. Okay, so the first theme relates to considering needs, risks, preferences and impact of research participation for community and for themselves. So this theme was developed based on information that we collected both from the staff and from the patients. And you can see under in each of those boxes, the kind of purpley and yellowy box, these are the sub-themes that were identified out of these major themes. So I'll pick out the important ones and just describe those with a bit of detail. So the first sub-theme I wanted to talk about was developed from the perspective of staff who took part in the research. So when they were considering the research project, staff reported feeling pressure, and this pressure related to feeling some responsibility to make sure that clients had a positive experience when they visited the primary healthcare service. And they were concerned that, you know, asking the clients to be part of a research project, but then also asking them about their mood might impact on their experience. And so they felt pressure around that to make sure that clients really saw their interaction with the primary healthcare service as a good thing. Staff also reported feeling pressure to respond appropriately if a patient became upset during a research interview or when they spoke to them about mood. So they were concerned that asked a question that perhaps a client might have a negative response to and they became upset. Staff were concerned about how they would respond to that to make sure that the patient was looked after and that they were safe. Many staff also talk about feeling the pressure that they felt because they weren't just staff members and they certainly weren't just researchers, but they were also part of the community as well. So they were known and they had extra pressure in their dual roles within the community. For patients, they spoke about when they were considering the needs, risks, preferences and impact of research participation, they reported feeling the need to feel comfortable. And this was the importance of feeling comfortable in the physical environment where the research was being conducted and where they were having the discussion about their mood. They also reported the importance of having a connection. So this connection was between themselves and the staff member who was asking the questions, who was asking them about their mood and who was asking them about if they wanted to take part in the research. This was sometimes, but not always, a cultural connection. It was sometimes with Aboriginal staff, but also sometimes with non-Aboriginal staff who they felt connected with and like they could trust. So next, we were interested in really exploring this idea about how staff experienced the process of going through and talking to their patients about research and about social and emotional wellbeing problems. And what we found was that many of the staff who were involved, and so remember this is staff from 10 different primary care services around Australia, many of them reported that during the process of the research project and asking about depression, they actually enhanced their skills and they gained confidence as they went. Many staff reported that the experience of going through the research enhanced the relationship that they had with patients as well, and that many patients had positive outcomes as a direct result of them asking them about their mood as part of the research project. So you can see here from these two quotes, this first one, this staff member, an Aboriginal health worker, described how they felt that it was a really good outcome for the patient, having gone through the project and actually answered the questions about their mood, and that was a really positive and empowering experience for them as a clinician. This second quote here talked about how difficult it was for them when, after they'd asked them about their mood, after they'd asked the patient about their mood, a patient became really upset and she bawled her eyes out. But at the end, she thought it was actually a really positive thing because she really needed to get it out of her system. We did hear one story from one staff member who was a nurse who reported a negative situation that did occur because the conversation that they had where they asked about mood actually triggered something within the patient and they became upset, but it wasn't until after the interview, and the staff member was unaware, so couldn't do anything about it for a few days until the patient got back in contact with them and they were able to follow up. But this only happened one time out of 500 interviews, and so it was quite rare. And they were in the end able to support the patient once they got back in touch, and they then ended up referring them on for treatment. So finally, the final major theme was around patients speaking openly about their social emotional well-being. So both staff and patients reported that patients appreciated the opportunity to speak about their mood as part of the research. As you can see here from this first quote, this participant reported that they were happy to take part in the study and they thought it was great that the research was being done. Many patients reported this type of feedback after they'd taken part in the research. They really saw well-being as an important thing in their community, and they were really happy about being part of finding some answers and solutions within their community to what they saw as being a major problem. Oh, sorry, I'll just go back a slide. And this second quote was from a staff member who also reported that they felt it was really positive for patients to be asked about mood, particularly the question around suicidal ideation. Many staff members reported that it wasn't something that they routinely asked about before the research, but they really felt that many patients appreciated the opportunity to talk about thoughts of self-harm or suicidal ideation. And finally, there were many, many stories that were shared as a result of asking the questions about mood. As you can see here from this story, there was where this gentleman, as a result of being asked about mood, shared a lot and spent a long time talking with a staff member about his history. And unfortunately, this gentleman actually passed away a few days later, but the family provided feedback to the clinician saying that it was such an important thing that he'd actually taken the time to sit down and talk with the staff member about his history and his family background, so close to the time when he unfortunately passed away. And this staff member was just really happy that they'd had that opportunity to have that conversation to support this person at such a difficult time. Okay, so what does all this mean? So I think with regards to speaking about depression and mood in primary care, although we did hear that there were a lot of concerns from staff initially about asking the questions about mood, about suicidal ideation and intent, many people who took part in the study were actually okay with talking about their mental health, and many benefited from these conversations. This was a real surprise to the staff who were working on the study, but a really important thing for us to remember that some people obviously might not want to talk about mood and about well-being, but there's a large group of people out there who were actually comfortable with it and who actually saw it has been a really useful thing for them and for their community. For substance use, despite the thoughts that we had going into the research, there are in fact many opportunities to engage with Aboriginal men who use substances in primary care. So just remember, we spoke with men as part of this study, so we can't generalise this to women, but for the men who took part in the study, half of them had actually spoken with somebody at their primary healthcare service about substance use at some point. So there are opportunities here. And for these men, some of them are getting help, but unfortunately some of them are not. And so there are opportunities for us to improve how we manage these discussions when they do occur. So what does this mean? Well, I think it means that when we've got staff who are culturally appropriate and who have the appropriate training and skill set, that they should be encouraged to ask these questions around mood and around well-being and around substance use. But we need to have time for these conversations, because sometimes these conversations can go on for quite a while, as I'm sure you're aware. And having a relationship that's established between the client and the clinician and the health staff is a really important part of these, developing the trust and the background to have these conversations. As you can see from the range of requirements and preferences from the people who took part in this research around what sorts of treatment they'd like, whether they wanted to be treated by the GP there and then, or whether they wanted to be referred externally, we need to have a range of referral and care planning options available. One of the great things that came out of the work with the residential treatment service was one of the strengths that's really existing within Aboriginal communities at the moment, which I'm sure you're all aware, around these cultural connections and around how important it can be to develop and foster cultural connections. Men's groups and similarly other community-based groups, as well as having an Aboriginal workforce, so health staff that are Aboriginal for clients to talk to, is a really important strength that we can build on going forward. Finally, I just wanted to mention the APHQ9, and there are some other tools around that have been culturally adapted to be appropriate and meaningful to Aboriginal and Torres Strait Islander people, and have also been validated. So if you're looking for tools, the APHQ9 is one, which can be used for depression screening, and I've put a link up there, and I'm happy to talk later or offline if anyone had any questions about that tool. And then there are also some treatment guidelines around which might be useful as well. So I'll finish there, but I just wanted to finally just thank and acknowledge the participating services who've taken part in the research, of which I've been very lucky to work with 10 services from around Australia, as well as the participants and the staff who've taken part. You can see up there in the top left-hand corner, that's some artwork that we had done for the Getting It Right study. We think it's beautiful, so I thought I'd put it up there to add some colour. And also just to acknowledge the co-collaborators on both of these research projects. So thank you. I'll finish there and hand back over to Vilma.
Thank you, Sarah, for your presentation. That was really interesting. It's important to seek help, and so the following slide will provide a list of mental health and alcohol and other drug services that can help you. We would also like to mention that the Alcohol and Other Drugs Knowledge Centre has produced the AOD Connect app. It's a national directory of alcohol and other drug treatment services for Aboriginal and Torres Strait Islander people. The app is intended for Aboriginal and Torres Strait Islander alcohol and other drug workers, community members, or any health professional working in the AOD sector. We have an opportunity now to take questions. If you would like to ask Sarah any questions, you can type them into the chat box located on the bottom right of the screen. Looks like we have a question from Andrea. Thank you, Andrea. If you'd like to go ahead, please.
Yes, I see. I didn't click before the microphone, sorry. I just want to ask if the study was done in communities, in Aboriginal communities, where they have permanent staff, permanent primary care staff, like nurses, GPs are permanent, or was, because I live in a community when it's not permanent staff, so the GPs and the nurses change all the time. So I just want to know that the conclusions that you have in your study came from services where the staff provide are based in the community and are make these long-term relationships with the patients.
Yeah, great question. Thanks, Andrea. Look, it was a range of services, so 10 services, but from my understanding, most of them had ongoing roles within the service. I'd have to chase up. We did actually collect the number of years that staff had been working with the service. From memory, I don't have it quite on hand at the moment, but from memory, most of the staff had been working within the community for many years. And many of the staff had been there for their whole careers and had grown up and worked and lived within that same community. So it wasn't a situation where staff were rolling through on an ongoing basis, but there were a few short-term staff, but as a whole, they were mostly more permanent staff.
Do you think that it will change if the primary care staff is changed time to time, we'll have different conclusions. Try to see how much we can really apply this for our community when we have a staff who are not permanent, no, we are very remote.
Yeah, sure. I think, look, part of it was to do with having a relationship with the staff member, and part of it was to do with having a relationship with the clinic. So some of the clients reported, you know, oh, it's Dr. So-and-so that I really get along with and who knows me well. And some of them talked about, oh, all the staff at whatever the health service is are great, and they all look back and they understand what's going on with me. So I think even when there's not, we don't have the opportunity, because obviously there's limitations within the resourcing and within the health sector around staffing, even when we don't have the opportunity to have the exact same staff member there are opportunities to develop that trust and within health services and create that kind of culture.
Okay, thank you.
Thank you, Andrea, for your question. That was great. So if anyone doesn't have any more questions, and it doesn't look like anyone is typing, we'll wrap it up there. If you do have any questions, please don't hesitate to contact us. Thank you everyone for joining us today and being part of this AOD Knowledge Centre webinar, and a special thank you again to you, Sara, for the great presentation. We really appreciate it. If anyone has any feedback or would like to forward some questions or queries, then please contact us. Please note that this webinar will be available as a recording and a PDF handout in the future. Make sure you subscribe to our monthly newsletter to find out when the next AOD Knowledge Centre webinar will be held. Thank you and have a great day, everyone.